must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hey everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. My name is Brandon Pollen, and I am your host today. And today I have the distinct pleasure of welcoming Dr. Carol Beckel on the show today. And for those of you who aren't aware, Dr. Carol Beckel is the current DCE-ACCE co-chair of the Academy of Physical Therapy Education Clinical Education Special Interest Group. And, you know, throughout this podcast, we're going to call the Special Interest Group the SIG for short. And she is also an assistant professor of physical therapy and athletic training at St. Louis University. She obtained her PhD in educational studies from St. Louis University, and her research interests include best practices in clinical education and accommodations for student disabilities in clinical settings. Now, Carol, thank you so much for all of your service and dedication to the profession and for our listener.
You're welcome. Thank you for the opportunity to talk.
Yeah, no, absolutely. You know, I recognize that there are probably a fair amount of listeners who perhaps have not heard of you. Would you mind just giving our listeners some brief background into who you are and kind of talking about your journey to academia and how you got involved with the SIG?
So I graduated from St. Louis University with my undergraduate degree in physical therapy in 1992. And I worked as a clinician full-time, mostly in geriatric, a little bit of pediatric, 5 years in a hospital setting, 5 years in home health. And that entire time, I had the privilege of being a clinical instructor for various levels of students from a variety of different academic programs. And I really enjoyed that aspect of my clinical practice. So a part-time opportunity opened up at St. Louis University to help with the clinical education side on the academic side. And I took that position, and within a year it became full-time. And it really, it's an honor, I think, to work with students from this side as well and preparing them to go to the clinic and hear that excitement in their voices when they start putting all the pieces together. The DCE that preceded me, Dr. Dorinda Sargent, was really big on, when we went to professional meetings, to attend those specific interest meetings related to clinical education. She got me involved very early on in my first year with our regional consortium. And then I kind of sought out our Eastern District through our MPTA. So I tried to find all those different levels of professional practice and clinical colleagues at different levels. And that was how I really was introduced to the ClinEd SIG.
It's so interesting. The more I do this podcast and the more I listen to people's stories on how they got involved in the organization, and some of them will vary immensely. So it's always fascinating to kind of get everyone's perspective on that. And, you know, of course, knowing that the education section of the APTA recently has changed its name to the Academy of Physical Therapy Education, I'm sure there are some of our listeners who are perhaps kind of curious as to, you know, what's the reasoning that the education section changed its name to the Academy of PT Education, to give some context?
Well, for many, many years now, we've had sections. And when we looked around at other peer professions, we started to realize section wasn't a very common term when you started looking at areas of specialization. Academy was more of a way of saying this is a particular area of practice, both clinical practice and research practice. And we felt like it was a way of acknowledging that real practice area and the importance of education, not just in the classroom, but in the clinical setting as well, too. And so we voted on this last year at the then education section business meeting at CSM in New Orleans. And it was, I don't know that it wasn't unanimous, but it was a pretty strong decision to move and change the name. There was contention, because there always is. There's always good discussion about it. and pros and cons to it. But in the end, that motion did pass last February.
Gotcha. And it's been funny because ever since that motion has passed, I have probably still recognized it as the education section with work and stuff so often. And it's still starting to finally kick in now that it's the academy.
Well, the funny part is now when I write APTE in an email to somebody, they always say, don't you mean APTA? I said, no, APTE is a portion of a specialty area within APTA. So we use a lot of the same letters over and over in our profession. I have learned that.
Yeah. And I think it's just time we'll get used to it because I've gotten better at it for sure. But I know there's definitely sometimes I'm like, oh yeah, it's the academy now. But Carol, I also recognize that some of our listeners may not be APTA members or specifically academy members. So from your perspective, kind of being involved to the level that you were and your experience and your involvement, what would you say are kind of the main reasons that someone should be a member and kind of what's the value that membership brings to them?
In terms of the APTE, when you look at our role as physical therapists, I always tell our students, we're really frustrated teachers because we go in with our patients and we teach our patients every day, and we teach our colleagues, and we teach other professionals, and we teach caregivers for our patients and clients. And several years ago, in then education section meetings, we really latched onto the idea every PT and every PTA is an educator. So to me, the Academy of Physical Therapy Education, it crosses every single discipline or specialization within our profession. And it really looks at the heart of how are we developing our profession by the development of our professionals for future progression. And that, I think there's a vested interest for all PTs and PTAs. And how is that moving forward? We've come from mostly undergraduate, masters, where all PTs now are getting a doctor of physical therapy. That took a lot of work by educators and clinicians together to figure out what do we need for best practice. So for me, there are so many of my colleagues that are members of the APTE and then their specialty area. And I always say, no, this is my specialty area, is education. But it really is at the root, I think, of everything we do in physical therapy. Many of the other academies and sections within APTA have put together what they believe are the best standards for entry-level practice. And so that's really helped inform educators who may not be specialists in all these different areas. What do we need to have in that entry-level program? Now, having said that, we can have students in this program for 8 years and nobody wants to pay 8 years of tuition. So then it's really figuring out how do we meld that and develop it so that we refine it and have the best possible graduate from both PT and PTA programs to serve our greater community.
Right. And I wonder too how difficult that must be compared to that and also having it meet CAPTE and FSBPT criteria.
Very rarely does somebody just come back and go, you got everything you need. There's always that deeper investigation and just simply the refinement of what we teach based on the evidence that we've gained. Yeah. What we teach now in 2018 is different than when I started working at St. Louis University in 2002, because you have to evolve, you have to update, you have to make sure you're teaching your students the best practice standards you can. And that helps to move the needle a little bit in the clinic then as well too. Clinicians love for the students to come out and say, what's the latest? What's the greatest? What's happening? What's the research? Can you pull articles for me? It's really just a great blend within our community as well.
Oh, absolutely. No doubts. So to kind of get an overall perspective of kind of what you do in this role, a little bit more specifically, what are your duties as co-chair of the Clinical Education SIG to give some context on kind of what that role entails and what you go through?
So the CSIG is a little bit unique in the fact that it does have a co-chair. So the co-chair really represents the two branches related to clinical education, the academic side and the clinical side. So on alternating years, we elect a new chair. My role as the academic co-chair is to bring the perspective of those DCEs and ACCEs, both in PT and PTA programs, when we look at the needs and what we're driving for in our practice in clinical education. Then the clinical co-chair makes sure we do not forget about the clinician perspective and the important role of the clinical instructor and the site coordinators of clinical education. So that really helps to kind of balance out. It can get really heady just looking at the academic side without taking into account that practical side, that clinical side, okay, you guys can have this great tool, but this is how we execute it in the clinic with productivity standards and the needs of our patients. We have to keep it realistic for both of those communities.
Yeah, I really like that checks and balances system that's kind of built in there, because I think that's really, really an important point to really make sure that, the pendulum doesn't swing too far one way and we lose sight of something. So I really, really like that.
Exactly.
Just curiosity here, what is the brief history behind how the SIG formed and how has the SIG transformed to kind of what it's doing today?
I don't have the exact dates on the SIG. I can tell you that with some quick research by Julia Rice up at APTA with the historian, we can find dates back to 1942 for the physical therapy school section, which we're assuming eventually evolved into the education section and then eventually to the academy. So you're talking about that the focus on education, at least into the 40s in some formalized area. My guess is the APTA has been around for about 100 years, and we've been talking about how to educate physical therapists for about 100 years. I'm not sure when the special interest group really evolved. I know it's been well into the 80s and probably 70s that there's been a specific conversation with those people most intimately involved in clinical education based on conversations I've had with my predecessors. Since my time in the SIG, I can say that it is a very vocal, very engaged group. We are known as always needing the biggest room in any meeting because we often have about 300 members that will show up for any meeting. And we always have to have 2 mics, and there's always a nice queue of questions. And so I think over time, this community has really tried to look at the practice of clinical education, where we might have been more about just the practical, getting students out, getting students assigned. We've really started to look more closely at the research related to clinical education and best practices. And you've seen that, especially over the past 4 years. We had a large summit in 2014. The research that's been coming out in the clinical education community has really expanded on that.
Yeah, no, I think that's really helpful to kind of gain some perspective. And actually at ELC a couple weeks ago, that was actually my first time going to one of those meetings. And it was actually really, really enlightening, like learning a lot. But also I really loved the collaboration and the discussion that was taking place, right, and how it wasn't really rude, but there were critical points that were brought up, which I think is good.
Clinical educators are not shy. And this was a particularly very engaged conversation. And I think there are different times where the conversations have waxed and waned a little bit. What I really love about the CSIG and why I sought this position was it is also that dual collaboration between PTs and PTAs, as well as academics and clinical. So it really is all the potential partners within clinical education. We also collaborate with the National Consortium of Clinical Education, which is a component of ACAPT. So it's nice to have all these different partners, and we have different perspectives and different views. Our CSIG view is to look at the entirety of clinical education across PT and PTA. And so when we come to a common discussion point, and this common discussion point recently was around the CPI and CPI training, that affects both PT and PTA community. And we find that our PTA colleagues and PT colleagues, they have the same challenges. And so it's nice to be able to have everybody in the same room to have those discussions at times.
Yeah, no, absolutely. Because I think that's, like you had kind of mentioned earlier, it's just that ultimate way to cross collaborate and really get that insight. Mm-hmm. And I'm kind of curious just because, with the SIG kind of working on its aspects and kind of collaborating with some other organizations like you had mentioned earlier, I'm curious, how does the SIG interact and collaborate with the Academy of Physical Therapy Education specifically, and kind of how that avenue works out?
Mm-hmm. So I'm just through my first couple of board meetings. I was just elected in May. And my perspective is within the APTE. The APTE, the Academy, has the overview of academics, both PT and PTA. My role, along with my co-chair, Jay Lamble, is to really bring that perspective of what does that mean in clinical education terms. So if something came out of the Academy about best practices for students prior to their first clinical experience, we would want to have a voice in that, in saying, if we're talking about a PT, probably that first full-time experience is into the second year. we do have an opinion on student preparation before that, or for PTA students towards the end of their first year. So our role is to really make sure that clinical education community is always at the table when we're talking about anything with the preparation of entry-level PTs and PTAs. The SIG looks at what are things that are coming up and need to be addressed. And when I first started in May, one of the topics we were looking at is the increasing interest of students to participate and to pursue residencies while they're still in entry-level programs. So that's been a topic for a couple years. And we really tried to do some investigation and talk to some of our colleagues, both on the academic side and the clinical side. And we prepared a panel to have a discussion at ELC. What happened in August was we had a significant change with the CPI. And so the SIG has the ability to respond to that and say, okay, we're hearing from our membership. We have a listserv. We're hearing concerns from the membership about these changes. And it's our responsibility as the leadership of that membership group to really try to advocate and get answers and pursue questions about that. So I think a lot of times we help to kind of liaison between different entities. We have conversations with Liaison International, who oversees the CPI, the APTA staff that works also on the training in the CPI as well too. So it's kind of a way of, and I was contacted individually by membership. So it's taking those voices and collecting, okay, what are the concerns? And within our board, we have several DCEs and Jay as a clinical instructor trying to formulate what are really the questions and concerns to bring either to the academy, to bring to APTA. And these concerns we always bring to our academy leadership as well too. So we have their opportunity to advocate for the clinical community as well too.
Wow, it seems like there's a lot to do within the SIG.
Well, it seems like it's always evolving. And like I said, the clinical education community is not a shy, reserved community. They're very proactive. And if there's something that there's a concern, the CSIG board is obligated to be responsive to that. We may not always be as responsive as quickly as everybody would like, but we also try to look at what are all the pieces that have to go into place. You can't take a tool like the CPI and quickly do anything with it. And
Right.
So it's really trying to make sure that voice of the membership is still heard and we don't lose that in the conversations as well. To me, that's my responsibility as leadership within the CSIG.
And I think that makes a lot of sense. And you had mentioned earlier a couple issues, of course, that were talked about at ELC between time for residency interviews on clinical affiliations, the CPI, and a couple other things too. But besides that and what you had already mentioned earlier, what is some of the work that the Clinical Education SIG, or frankly, the Academy of Physical Therapy Education, are really working on, probably at the biggest now, to work on improving clinical education and variance with clinical education?
So a couple projects that got finished up before I came in was participation in a couple of the focus groups that came out of the summit. And so the Clinical Education Summit was co-sponsored by the then Education Section and ACAPT. And so there was membership from both of those organizations to look at entry-level practices or preparation before students go into the clinic. They looked at common terminology so that we were all kind of on the same page with things. My predecessor, Cindy Flom-Malin, helped to revise the manual for the Site Coordinator of Clinical Education, the SCCE, which is one of our new terms that came out of common terminology changes. And so it's really updating information along the way as well. Right now, I think probably for the next a couple of years, our biggest focus is going to be on the CPI. That's been a discussion point for many years within the clinical education community. That tool first came out in the paper form in 1997. Then it came out in the electronic form in 2008. So we're looking at a tool 10 years old that really needs some revision and updating. Technology has changed, so that's created some problems within the training as well. And so Jay and I have been doing a lot of collaboration right now with the APTA staff that's charged with that. We also have an upcoming meeting that I am attending as well on clinical education strategic planning. And so really trying to pull back a little bit and looking at the big picture. If you ask anybody, they would tell you clinical education is broken. That's been our party line for many years. I don't like to say it's broken, because to me, if it was broken, we wouldn't be graduating really excellent physical therapists and physical therapist assistants. It needs refinement. It's based on a very old model of internship that you learn from your elders and you learn through mentoring, which is fantastic. But we've gotten so much variability now in length of time and distribution of time in the clinic. It makes it hard when you look at other professionals to say, oh no, our clinical education is sufficient. Well, what's sufficient about it when you have programs that have 30 weeks to 52 weeks of clinical education?
Mm-hmm. Yeah.
So I think over the next few years, the CSIG will be intimately involved in, can we bring together, some of our scholars within this field and really look at clinical education and take the data that came out last year in the best practices document about clinical education. And we'll never be all the same, because we're in academics, the same is no good. We like to have our own thing. But can we have a better common sense of what we need to do with our clinical preparation to make sure our PT and our PTA students are ready to hit the gate running once they graduate?
It's been crazy the more just looking into it and just seeing all the variables that go into clinical education. And it's a very complex issue, because it's definitely not a simple solution. And, but what would you say? I mean, you had mentioned some great things already, Carol, in terms of resources, but what are some other key resources that the clinical education SIG provides to members to really help advance their clinical education practice or their clinical education model?
That's an area that I think we could do more of. In looking at our website, I would like to see us get more information updated on there. We need to update all of our common terminology. I would like it to be the location that a clinical educator, both academic and clinician, could go to and know exactly what's happening and what are we working on. And communication is always probably the biggest piece of what we do. And I'd like to see us improve on that and make it a little more streamlined. I think we are the advocates for those clinical instructors that say it takes forever to complete the CPI, and all these glitches. And I know I keep coming back to that, but that's one of the most important things clinicians provide for the academic programs, is that ability to assess students. And we really need to make sure we're listening to the clinical educators on what do they want to see and how do they want to be able to evaluate students as they're coming through both PT and PTA programs. So to me, the advantage of being a section member is really getting an insight into what are all the components of clinical education. When we have clinicians that come to these national meetings and they hear us talking about, no, we have a common mailing date. So the common mailing date for commitments is March 1st. And then a lot of clinicians aren't aware of that. And so us providing that information to them empowers them to say, okay, don't ask me for something 2 years ahead. I want to work on this current year. And they're very happy to know the CSIG has put this voluntary date in place, and we really try to hold individuals to following that voluntary mailing date. So it really is that way of getting information, I think, especially to clinicians that somewhat are transient in the clinical education process. They may not have students with them all the time, but they may have students with them a couple times a year. So the CSIG becomes that common location of, okay, I better check back in. Is there anything new? We've got new terminology. Okay, now I need to update the terminology that I'm using related to clinical education. I know I've responded to a lot of our clinical coordinators and say, okay, you're not a CCCE anymore. You're an SCCE. And this is why we've made that name change as well.
Mm-hmm. Well, I think that's a really good avenue, because I think having one central location for updates to notifications on changes and stuff, I mean, it's only going to make things better and easier. Right. And you had mentioned this earlier, and of course the CPI and a couple other things taking precedent right now, which is totally understandable. But let's say, for example, that the CPI issue has magically been solved and now it's on to bigger and better things. Mm-hmm. So what is if the plan has been discussed already, what is the clinical education SIG looking to do in the future, apart from the CPI and what you had mentioned, to continue to contribute to improving clinical education?
It really is that partnership of trying to identify best practices within clinical length of time, clinical practice. What's the best distribution of time? We're starting to have more conversations now at meetings about, are there other avenues other than just sending students out to the clinic? We saw a lot of information come out of ELC that looked at use of simulation. The Oxford debate was all about whether or not to use simulation as a different type of way to prepare students before they go out to the clinic. And so I see the CSIG being a very vocal group in discussing that academic component. I would like to see that discussion both within PT and PTA academics. NCCE is an excellent representative for PT academic programs in the institutions that are members of that. We have the ability to be a voice for individuals. So you can be an individual member in CSIG and to have that dual PT and PTA. I don't think it helps us professionally if we only address clinical education related to physical therapists without also addressing clinical education related to physical therapist assistants. It really should go hand in glove. If we're making changes, what does that look like within a PTA curriculum of a 2-year curriculum as well to make sure these professionals are as well prepared in the clinic as what the PTs are?
Yeah, no, and that makes sense. And Carol, I'm going to ask kind of one follow-up because you kind of mentioned that, of course, trying to look into ways to make everything better and kind of find out what's the right mode, method, and delivery and duration. I know this is a big question, but what do we know currently right now from the research that's been done, whether that be more research-based or anecdotal, frankly, on what are some things that are overall tending to show as, that's more of that thing's more working versus, no, that's not working so much?
I think we've realized that time in the clinic, uninterrupted time in the clinic is helpful to students. And so you've seen a trend over time, moving away from shorter clinical experiences to longer clinical experiences. What we don't have in the research yet is what is the ultimate time? So what is that minimum amount of time as a student to be prepared versus okay, at this level, this maximum level, everybody should be prepared at that point. That research is still a little bit fuzzy. In my own personal research, we made a big change in our clinical education program away from shorter experiences to longer experiences, and my data didn't really show that they significantly performed better. So that was kind of a confusing question. So the data coming out of clinical education is still morphing a little bit. What we do know from an article that was done, research that was done, is that certainly clinical experiences throughout the academic program seem to be of benefit. So an early exposure versus an interim exposure versus those extended final exposures, that seems to be an effective model when you look at the ability to ultimately pass the NPTE. That seems to help in preparation. But we still don't have that what's the ideal length of time. And there's some real controversy within the clinical education community. There are many individuals that feel very strongly about the year-long final internship. There are others that don't feel as strongly about that and feel like we don't need that 52-week model to say a student is really at entry level. So while we've had a lot of research come out, we're still having those philosophical discussions and arguments, and they're very civil arguments, but still really trying to engage each other. I think ultimately we want to find the balance so that when our students are hired, they're ready to be entry-level practitioners, but we're also very sensitive to the fact of the cost of education as well, too. So not keeping students in clinical education longer than they need to while they're paying tuition. And so is there a mixed model that we look at where they do a certain point, they graduate, and then they complete additional work beyond that, similar to more of a medical model? We just don't know. We're still looking at that research to see if there is a significant difference in preparation or an ultimate outcome for students with different preparation.
Yeah, because it's been interesting seeing just the amount of differences there are within programs with how they do their clinical education. I know some I've heard do it very, very short experiences and they have one longer at the end, which makes sense from one point of view. But then, like you had said earlier, it gets into the generalization versus early specialization. And then, that's another issue too.
And as a profession, we're really trying to sort out, our accreditation standards for both PT and PTA say the students have to have a breadth and depth. So they have to have breadth across patient ages, patient conditions, different settings. It's not mandated what that breadth has to be, but we have to be able to demonstrate that our students have different exposures. But we're also moving towards more specialization. And so in some programs, students are allowed to do more of a deep dive in one particular area within clinical practice. So it's really a challenge right now. I think there's a little internal conflict just within our own profession. What do we want it to mean when we say we're a physical therapist? Do we want it to mean, we've always said entry level means you're prepared as a general practitioner. Is that really still true? Are there ways of allowing students before they enter into the workforce to have a little more definition of what they want professionally? We also have really big regional differences. Mm-hmm. When I talk to my clinical practitioners in what I call the Central Midwest Corridor, they're more interested in clinical experiences up to maybe 16 weeks, maybe 20 weeks. If you look at the coast, they're really interested typically in those longer experiences, that 16 plus week experiences. So now you're trying to look at, okay, let's figure out best practice of clinical education and meet the needs of all these different, practitioners, sending students to clinical practice areas that they may not be that interested in, but it's kind of like spinach. It's good for you. It's good for you to know what an acute care setting is. You certainly should know what outpatient orthopedic practice is so you understand that continuum. So I always see the discussion about clinical education becomes this larger philosophical, okay, but who are we and who do we want to be?
Yeah.
If we know that, then we know how to drive towards that a little bit better. And I think that discussion is still evolving. And that's that APTE level discussion that we can bring our component from the CSIG to. Yeah, but don't forget about this really critical piece of preparation. I do a lecture every year that looks at the national level of clinical education. And they're always amazed when I talk about the number of academic programs, PT and PTA, so the number of students being placed every year. And so I always tell them, look, when I'm working hard to get you a clinical placement, it's not because people don't like you. They don't know you. It's because there's such a demand across the country in really looking at that excellence in clinical education.
Right. And has that become, do you think that has contributed to maybe the difficulty with clinical education too, with programs having to find a site?
Absolutely. I think when you look at the growth of programs, the growth of student enrollment in those programs, and you balance that with the increasing focus of productivity on clinicians, taking a student for free. Now, we have studies that say it does improve your productivity, and that's another thing the SIG is trying to get out there of. You can have better productivity with a student. It takes a little time, but then it balances out and you'll have greater productivity. And I think that research is becoming more conclusive that, yes, having a student is not an overall detriment to your productivity. Trying to get that information out right now is a challenge. And not only to clinicians, but to managers and to owners and to hospital administrators, really trying to get that message across is critical to keep clinical education evolving.
Yeah. It was interesting when we talked with Gail Jensen in the past, and she had mentioned some of her research coming up. And when they did the research, actually looking at kind of the successful clinical sites, they asked about like, what are the barriers? And specifically they wanted to inquire about cost. And she's like, and we inquired about cost every which way, and no one said anything about it. She's like, they said it was time. And she's like, and that was just mind blowing to me.
Yeah. Yeah. That study was an amazing, just provided some amazing information and a reflective look on what does it look like when these students get out. And when I talk to clinical educators, the clinical side of it, I find that most of them say, I don't want you to pay me. I don't want you, we don't need reimbursed for taking students. We need to be respected. We need to have a voice. We need to have opportunities to learn from the academic side, whether it's access to library or access to continuing education courses. They want that feeling of respect and equality with the academic faculty. And again, I think CSIG brings that together of saying all of these voices need to be involved in this discussion and in really engaged discussion.
I know we've talked a lot about clinical education and some things going from there. But besides what we've talked about, and from your perspective and your seat, you seeing all these different things within clinical education, what are some of the other big issues within DPT clinical education? And what do you personally think are some solutions to these issues?
So if Carol could be the ruler of the day.
Yes.
I've talked about this for years, that the CPI allowed us a central access point for information about clinical sites. So clinical sites can upload information through a tool called the Clinical Site Information Form. You can argue we have not been terribly successful on that, and that's another discussion of trying to get information about clinical sites. What we don't have is a central clearinghouse for information about the academic programs. So there's no way for a clinician to go in and just quickly scan and see, okay, St. Louis University has students out here. Washington University, also in St. Louis, they've got students out here. Maryville, also in, So our consortium puts together a table in all of our consortium schools when everybody goes out. I would love to see information like that nationally so that clinical educators can get as much information about the academic programs as possible. And we've got that information sharing. I think articles that came out in 2014 that talked about the centralizing process of looking at a clearinghouse for bringing commitments in and then having that distribution, I think that would help the clinician side of it greatly versus them getting individual request forms from every academic program. It's really kind of this amazingly archaic system that you can say it's broken, but it still works every year that I get commitments. We have to work for them. Sometimes we have to make those extra phone calls. So I think there's ways we could really streamline that process to make it easier for clinical faculty. They've talked about common start dates, so that would improve their ability. They could onboard a larger number of students at the same time. And I've got a couple clinical partners that they will take several of our students on a particular rotation because they say, look, I'm orienting one student or I'm orienting 6 students. If I can do it all at the same time, I can get all of these students on at the same time.
Mm-hmm.
The hard part with that, and when you start talking about common and similar, you start to get a little pushback on the academic side of that academic freedom. We want to set up our academic program because of this unique factor or because of this philosophy. So it's trying to find that balance of we've got to listen to the clinicians, we've got to listen to their clinical voice and what's going to help facilitate their ability to take students. I believe clinicians want to work with students in the clinic. I know for me, when I had a student ask me why, okay, that's a really good question. Let's sit down and talk about it. And it changed my day and it changed my thought process and it made me a better clinician. I believe clinicians want that challenge. They just can't have it at what they believe to be a detriment to their job.
Yeah.
So we need to keep working on ways to improve clinical education, to make it more accessible to a wider range of clinical sites and therefore clinical educators.
Mm-hmm. No, and that makes sense. And I'm curious to hear your take on another issue that we haven't really talked about yet, but that's been talked about kind of as a theme throughout. So the issue of even just variance in clinical instructor capacity and ability to provide accurate feedback. And then, so I guess my question is, what are your thoughts on that issue? And what are your thoughts on, do we need to change how we credential CIs? Do we need to change? I'm just curious kind of what you think on that, because that's definitely a big discussion.
Yeah. I guess I look at my academic career and I see variability in every teacher I had from kindergarten all the way through my PhD level. So I don't think we're ever going to eliminate the variability of clinical educators.
Mm-hmm.
What we need to improve on is the commonality in our manner of assessing students. And we started this conversation, right? Every physical therapist assistant is an educator. And I do believe that's why so many clinicians can just naturally work with students. But do they always have the best tools and the best information on how to give feedback? I know the credentialing courses, level 1 and level 2, have gone through significant retooling. Level 2 is rolling out now. And I think that curriculum will help to improve and help clinicians to identify ways to improve their entire program, not just their individual teaching ability, but what's the program within their clinical site. Level 2 is being refined as well too, to kind of catch up with a little more contemporary practice. It's still such a challenge because I know I've had clinicians come to my credentialing, level 1 credentialing courses, who I intentionally invited to try to work on some of their skills. And I remember distinctly one woman who liked to get students to cry, like that was a thing for her. And so I thought, okay, come to the credentialing course. And I remember on the last day, the second day, she said, well, this just proves what I've been doing is right. And I thought, I don't know how you listened for 2 days. I never once said, get the student to cry. Once you break them, then you have them. So I don't know. I love credentialing and I love the credentialing courses. And I know the majority of clinicians that come in and do those courses, become better clinical educators, there's always going to be those individual variances. And what I tell students is clinical instructors are no different than the individuals you're going to work with. So the ability to communicate with a wide range of individuals, and maybe you have a clinical instructor who's more introverted, that ability to figure out how to get feedback from that person and drive your own feedback and your own self-reflection so that they're more able to be responsive to that, that helps to increase your ability to work with a wider range of individuals. It always gets a little touchy when we say we should demand that everybody is credentialed. I always tell students, when you're working with people on a voluntary basis, your lever arm is about this long. So it's trying to balance that out. And I think it's similar to saying to clinicians, we want you to be the best practitioners in your work with patients and clients as well. So here's continuing education to improve that. Here's also better ways for you to be a teacher, and trying to go towards it in an affirmative manner. We want to help you to be the best that you can be, I think is the better avenue to try to bring people around. And there are just some individuals that decide they're just not good clinical educators, and that's fine. I would be a terrible manual therapist, and I identified that for myself early on in my career. So I don't do manual therapy. I always say kind of have dumb hands. They just don't feel things well. Why am I a physical therapist? That's a long story. But I think some people just can identify that that's not their best avenue.
Yeah. Yeah. And that actually is a really good point that you brought up, in that, we can only do so much because we're not also incentivizing necessarily to a degree. And that's huge as a clinician, because just anecdotally, we only get so much money that we have from that. And it's, it's hard. It is.
Incentives are challenging. And I think academic programs, we have a lot of discussions within the CSAG about what is it clinicians could benefit from. And we don't have common benefits yet. And that would be another area I'd like to see us try to move towards. What are common benefits? The DCE is the ultimate salesperson. And I was the worst Girl Scout cookie salesperson. But you become this salesperson because you're trying to sell your students and your students over this other academic programs in a very nice way. I always say it's a little bit of a blood sport, but we're very cordial at meetings. And then we go back to our offices and we're trying to make sure we get the spots that we want for our students. And I just think there's better ways we could do that. Again, centralizing some of those tasks, centralizing benefits that we can offer to clinical faculty and clinical educators that would make it a little less contentious between all of us and really be to the benefit of the students getting the best possible clinical experiences.
Mm-hmm. No, absolutely. I think that's a really good point to bring up. And Carol, I know that we've talked a lot about many aspects regarding education and such. And the last question that I'm going to ask is kind of our big cheese, if you will. So it's kind of the question that we ask everyone, because with us being called the Healthcare Education Transformation Podcast, we have to ask it.
Got to be moving.
Of course, right? And the amount of data we've gathered from this is just insurmountable at this point. So now I'm going to ask you, if it's something that either we've talked about earlier and you'd like to bring it up again, that's totally fine. Or if you want to bring something new, equally good. Mm-hmm. So if you could change one aspect of healthcare education, DPT or otherwise, which aspect would you change and how would you change it?
Whew. Boy, that is a big question. I would probably like to see a change within the assignment process. It is this mad race to figure out where you're going to place all of your students. And I actually tell my students, clinical education is the world's worst game show. You've got all these different rounds where you're trying to assign the students, and then you get a whammy and there's a cancellation, and then you're trying to roll with it and figure something out. And I would love to see more of a centralized program where clinicians aren't responding to every academic program, but they're responding to, this is the region we prefer to take students from, or even these are the schools we prefer to take students from. These are the timeframes we can take students. That all gets put into one system, and then I'm notified. Here's the commitments that you have. I think it would save so much time for the clinical faculty if they weren't filling out individual forms for every academic program. I think it would streamline my work because I wouldn't be losing this email from this person, or one person likes to fax it, or one person walks it across the street to us. I just think it would save a lot of time. And then we could focus more on the actual application of clinical education. Mm-hmm. My favorite part of my day is when I have a student in my office and we're talking about what they want to do and where they want to go and why they want to go there. And I can start talking about what I know about the different clinical sites and what a good match for them would be. That's the part I love. And so being able to centralize our commitments would reduce a lot of administrative work, both on the academic side and more importantly on the clinical side, to make it a little less contentious, a little less like a telethon where I'm calling everybody going, can you take another student? Can you take another student? It just seems like a centralization of that would really move us into a little more, as it is, civilized version of the placement process.
That's interesting because that's the first time I've ever heard that solution brought up on the show, which I love.
Well, it's not my original idea. If you go back, there was a JOPTE special edition in 2014 with 7 great position papers on clinical education. And that was one of the things that was put forward, is that attempt maybe at a regional level, but if we could do it at a national level, I think it would save a lot of time on both sides. But that's my dream. If I was ruler for a day, that's boom, I would do that first.
I like it. No, I like it. Getting something new on the show that we haven't heard yet. And for our listeners who perhaps want to look into that article that Carol had mentioned, just feel free to check out the show notes as it's there. You can take a read and kind of come to your conclusions on that. Well, Carol, this has been a really interesting discussion, and especially diving into clinical education, because again, this is a big topic throughout the education realm. Say, for example, that someone wants to find out more on some of the issues that we've talked about, or they perhaps just want to reach out should they have a question. Where can they best reach out and find you?
So if you go on the Academy webpage, there's a section webpage on that. It is member restricted, so I encourage you to be an APTA member because it does increase your access to resources. But my contact information is on there, or you can go to St. Louis University's website. My contact information is on there as well too. I think the CSIG website is good information. I also encourage to look at look at the webpage of our colleagues on the National Consortium of Clinical Education. They have a lot of similar information focused on the physical therapist education component, but it would be another great resource for individuals as well.
Well, Carol, thanks so much for, again, your service and all that you do for clinical education. And thank you so much for the time and insight this morning. It was really, really good to get this perspective, as I always love it when I learn something new. So,
well, good. I'm glad I could do that for you today. Thanks for the opportunity.
Yeah, thank you. Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.